Hello, I'm Chris Parker from the Royal Marsden Hospital in London. I'm here at GU ASCO in San Francisco with my friend and colleague Stephane Oudard from the Georges Pompidou Hospital in Paris. Now, Stephane, you've presented some new data at the meeting based on the COU-302 trial of abiraterone. Can you tell us about your data?
Yes, hi Chris. Yes, as you know about the Cougar 302 study, we looked at abiraterone plus prednisone compared to placebo prednisone plus placebo in a pre-docetaxel setting, and we looked at whether or not prior duration of hormonal therapy has an impact on the outcome, and we found out that in fact whatever the duration of hormonal therapy prior to study entry, abiraterone plus prednisone has a benefit compared to placebo plus prednisone. So this is a good point, for these drugs. And we looked also at different quartile 1 to quartile 4. Quartile 1 being the most aggressive patient population in terms of a very short duration of hormonal therapy, and quartile 4 being the patient having the longest duration of hormonal therapy. What we saw is that if you have a very long duration of hormonal therapy, you may have a greater effect of abiraterone plus prednisone compared to placebo plus prednisone. But when you look at the quartile 1, which is the most interesting things to look at in daily practice, because for us in daily practice, we don't know whether or not we should go for another hormonal therapy. We found out even in this quartile 1 that we can give to the patient abiraterone plus prednisone. What we could not look at it was for patients having less than 1 year of hormonal therapy, because we have only very few patients in this patient population, so we can conclude so far for this very aggressive patient population. But anyway, if you look at the global population, prior duration of hormonal therapy doesn't have an impact on whether or not you should prescribe abiraterone plus prednisone.
Just let me understand it. So patients who respond for longer to their first-line androgen deprivation, they respond for longer to abiraterone.
Yeah.
Presumably they also respond longer to prednisone in the control arm as well.
Yes.
But what you're saying is that the benefit of abiraterone compared with prednisone is maintained regardless of duration of ADT beforehand.
Yeah, completely right, yeah.
And am I right in thinking that the benefit is the hazard ratio for the benefit is the same in the 4 quartiles?
Yes, yes, approximately the same in the 4 quartiles. So it's much more, I would say, a prognostic factor than a predictive factor so far.
Right.
Yeah. So in addition to that, we also look at different other exploratory analysis with the Cougar 302. We also looked at alkaline phosphatase, and we found that if you have a high level of alkaline phosphatase and a high level of PSA, of course, these are bad prognostic factor and translate into a bad outcome, But we know that, in daily practice, for our patient, we may not look at all these particular prognostic factor in daily practice, because we just feel how the patient is going to handle with your drug. But anyway, hemoglobin, low hemoglobin, high alkaline phosphatase, high level of PSA are associated with a poor outcome.
Yeah, and in our practice we always look at albumin and LDH as well.
Yes.
If you look at all 5 variables, you get a much better feel, don't you, for how the patient's doing?
Yeah, completely right, yeah. So and in addition to that, for this Cougar 302 study, we looked at whether or not it's useful to, after this treatment with abiraterone plus prednisone, to maybe re-challenge those patients with abiraterone or to switch to enzalutamide, for instance. So it was quite a short, study, because we have only very few patients who could receive either abiraterone acetate, 44 patients, or enzalutamide maybe 33 patients. And we found out that the time to progression was less than 4 months. So saying that maybe we need to propose to the patient another treatment so far. But the problem is that we don't know which patient could benefit from enzalutamide, for instance, because we don't have any predictive factor which tells you which patient could benefit from another treatment.
Yes. So you mentioned enzalutamide. We can't sit here and not mention the Prevail trial. Yeah. So I think the data are now well known, big survival advantage for enzalutamide in the chemo-naive setting. What do you make of them?
Well, it was a very interesting study to listen to, and we were aware about this study by the press release. So, but looking at the ADA ratio of 0.19 in terms of rPFS in favor of enzalutamide compared to placebo was really, really amazing for us.
But I don't think it is. I don't think it's really fair because, I mean, after all, it's being compared with placebo alone. So you'd expect a really good hazard ratio, wouldn't you?
Yes, completely. You're completely right. I think that they should have compared enzalutamide to, I don't know, prednisone, chemo for symptom, for maybe I don't know. But of course, if you compare your drug with nothing, you have a great outcome. So I completely agree.
But we don't want to take anything away from the study because it's a great trial. And what about the survival outcomes? What do you make of those?
Well, all the endpoints are positive so far, and it's a great study anyway. And looking at toxicity, it's safe, I would say. If you look at seizure, for instance, we don't have a lot of patients, maybe one or two at least. So about now the overall survival data, well, it seems to the difference not so huge as you may want to speak about, but I think it's always difficult to look at overall survival in prostate cancer so far because we have so many additional treatment that we don't know what is going on. So, and I have in mind, the TAX-700 study for which it was a problem to look at OS. So, but anyway, all the endpoints are positive. The rPFS is usually in favor of enzalutamide compared to placebo. The PSA response and so on, the quality of life were usually in favor of enzalutamide.
Yes, it seems like really good news for patients, doesn't it? I'm surprised you said the survival benefit was modest. I mean, the hazard ratio, 0.71. I think that's a pretty impressive hazard ratio. I guess the median survival benefit was modest, just 32 months compared with 30 months or something like that. Yeah. But I think that just illustrates what a bad measure median survival is. We should be looking at hazard ratio, shouldn't we, not median? I
completely agree. Yes, I have in mind, the median overall survival, the difference is only 2 months. And if you look at the ADA ratio, it's translated into a 29% reduction risk of deaths in favor of enzalutamide. I completely agree. But I would have expected maybe to have a better difference in terms of overall survival. The gain of 2 months was surprising to me, and I would have expected to have a greater gain in terms of overall survival.
I think with longer follow-up, the median survival benefit would be much longer, more like 9 months, I would say.
I think we should have that, yeah.
But you mentioned in passing the TAX-700 trial, and that was presented here as well, a trial of TAX-700 versus placebo in the post-docetaxel setting. Tell us more about that. What do you think of that?
Well, I think it's always difficult to come after the same class of drugs such as abiraterone, because TAX-700 has the same activity and as abiraterone. So this drug arrived in second. In a field in prostate cancer where now we have a lot of drugs available, and it was a problem for the TAX-700 study because a lot of patients could have, for instance, in Europe or in US, in case of progression disease, they could have access to the expanded access program for abiraterone, and also they could have access to the MDV drug. So, and therefore, in this study, if you look at rPFS, the rPFS is in favor, of course, of TAX-700, whatever the country. But if you look at OS, this is a problem. And in this study, the primary endpoint was OS. So if you are a statistician, you have to say that the study is negative so far, and you won't be able to give the drug to your patient because maybe the drug won't be approved by the FDA or the EMEA. So what we are going to do now for our patient, we think that we may have a drug which is useful, but we won't be able to use it.
Yes, I think that's a very good summary. It's striking, wasn't it, the geographical variation. So in the US and in Europe, where we have availability of abiraterone and enzalutamide, it was a completely negative trial. And in other parts of the world where the patients didn't have access to those new drugs, it was a positive trial and improved survival.
Yes. So now maybe about toxicity, it's maybe different because we have treated a lot of patients in this study, about 50 patients, and we found out that sometimes you have elevated amylase and lipase marker, which do not translate into a pancreatic symptomatic disease. But anyway, you are sometimes afraid, to tell to your patient, well, we're going to continue the drug, whatever the elevated level of amylase and lipase. So you want some time to discontinue the treatment just to see what is going on and restart the treatment after a while. So maybe this drug is less easy to handle as compared to abiraterone, I would say.
Yes, although I guess it's a bit academic because it won't be approved now. Well, thank you very much for talking to us.
Thank you, Chris.